She did everything her doctor asked. Margaret was 74 years old, a retired school librarian from Phoenix, the kind of woman who kept a color-coded medication organizer and never missed a single follow-up appointment. Her blood pressure had been running high for years, nothing alarming, but her doctor wanted it lower. So they worked on it together, added one medication, then adjusted the dose, then added a second, and it worked. Her pressure came down beautifully, 122/76. Her doctor printed her latest results and actually said the words, "Margaret, you are a model patient." That was a Thursday. The following Sunday night at 2:17. In the morning, Margaret got up to use the bathroom. She stood up from the edge of her bed, took 2 steps, and the floor came up to meet her. She didn't trip. Nothing was in her way. Her blood pressure, which looked perfect on paper, dropped so fast when she stood up that her brain ran out of blood for just long enough. The hip fracture required surgery. The surgery led to a hospital-acquired infection. The infection led to 6 weeks in a rehabilitation facility. And Margaret, organized, careful, compliant Margaret, never fully returned to living alone. She is living with her daughter now, not because she had high blood pressure, because her blood pressure was brought too low. I am Dr. Pablo, a board-certified geriatrician with 18 years of clinical experience working with adults over 60. And what happened to Margaret is not a rare tragedy. It is a pattern I have watched repeat itself across decades of practice and across thousands of hospital admissions that never needed to happen. Today I am going to tell you what the most recent research actually says about blood pressure targets after age 70. I am going to explain why the number your doctor is aiming for may have been designed for someone 30 years younger than you. I am going to show you a 3-minute test you can do at home tonight that can tell you whether your current medications are putting you at risk. And I am going to give you the specific blood pressure ranges that research now associate with the longest survival in older adults, because that number is not 120/80, and every person over 70 deserves to know that. Before I go any further, I want to tell you that the single most dangerous point in this entire conversation is coming near the end, and it has nothing to do with how high your blood pressure is. Stay with me, because when we get there, it will change the way you think about this completely. Here is what is happening in doctors' offices across this country every single day, and why it matters to you personally. A 78-year-old man comes in for a routine checkup. His blood pressure reads 144/86. His doctor opens the standard guidelines on the screen, sees the target below 130 systolic, and reaches for the prescription pad. This is not negligence. His doctor is following guidelines that have been in place for years, guidelines built on decades of research showing that lower blood pressure prevents heart attacks and strokes. That research is real. For a 50-year-old, getting blood pressure under control is one of the most important things they can do for their long-term health. The evidence on that is not in dispute, but something fundamental and measurable happens to the cardiovascular system after age 75. Something that changes what these numbers mean and what they should be. And the research that documents this has not yet made it into everyday medical practice in any consistent way. That gap between what the studies now show and what is happening in examination rooms is the gap that sent Margaret to surgery. A study published in JAMA Internal Medicine followed 15,342 adults over the age of 75 for an average of 5 years. These were not carefully selected healthy volunteers. These were real older adults, people with diabetes, prior strokes, heart disease, varying degrees of frailty. Researchers tracked their average blood pressure and monitored outcomes over those 5 years. They divided participants into groups by systolic pressure below 120, 122/130, 132/140, 142/150, and above 150. The results were not what the conventional wisdom predicted. The group with the lowest mortality rate, the group that lived longest, maintained systolic pressure between 130 and 140, not below 120. The group that achieved that textbook perfect pressure below 120 had a 28% higher rate of serious falls requiring hospitalization. They had significantly higher rates of acute kidney injury, and their overall mortality rate was 14% higher than the moderate group. The group above 150 had elevated stroke and cardiovascular risk as expected. But the finding that should have made national news, the finding that most patients are still not hearing, is that very low blood pressure was just as dangerous as very high blood pressure. The sweet spot was in the middle, and that middle is higher than your doctor's current target almost certainly reflects. To understand why, you need to understand 3 things that happen to the cardiovascular system with age, because without this foundation, the numbers alone don't make sense. The first is arterial stiffness. Your arteries are not passive tubes. In youth, they are elastic. They expand when the heart pumps and absorb the pressure wave, then recoil to keep blood moving forward. With age, a process called arteriosclerosis, distinct from the plaque buildup of atherosclerosis, makes the arterial walls progressively stiffer. Think of a brand new garden hose compared to one left in the sun for 20 years. The old hose does not give when your heart pumps blood in too. Stiff arteries, they cannot absorb that pressure wave. This means your body requires a somewhat higher baseline pressure to ensure adequate blood flow reaches your brain, your kidneys, and your extremities, especially when you are upright and blood must travel against gravity. Artificially suppressing that pressure below what your stiffened arteries need does not make your cardiovascular system younger. It simply deprives your organs of the flow they require. The second change is in your baroreceptors. These are tiny pressure-sensing structures located in the walls of major blood vessels near your heart and neck. Their job is to detect changes in blood pressure moment by moment and signal the brain to compensate. When a 25-year-old stands up from a chair, their baroreceptors detect the immediate pressure drop and within milliseconds trigger responses. The heart rate increases slightly, blood vessels tighten, and pressure stabilizes before they have even taken their first step. You never notice it because it works perfectly. But baroreceptor sensitivity declines with age. The response slows, the compensation is delayed. So if your resting blood pressure is already being pushed below 120 by medication, and then you stand up and your baroreceptors are slow to compensate, you get a sudden and dangerous drop in blood flow to the brain. You feel the room tilt, you reach for something, sometimes you find it, sometimes you do not. The third change is in how your body processes medication. Your kidneys and liver filter and clear drugs from your system. Both organs become less efficient with age, not because anything is wrong with them, but because this is a normal part of aging physiology. A dose of a blood pressure medication that is perfectly calibrated for a 60-year-old can be effectively too strong for a 78-year-old. The drug stays in the system longer, accumulates to higher concentrations, and produces effects that are more powerful than intended. This is one reason why medication side effects in older adults are so common and so frequently misattributed to just getting older. The dizziness, the fatigue, the foggy thinking, these are not inevitable features of aging. In many cases, they are pharmacological. They are dose effects. Now let me give you the specific blood pressure ranges that current research supports for different age groups, and I want to be clear that these are evidence-based ranges, not arbitrary numbers, and they should always be interpreted in context with your full medical picture alongside your physician. For adults between 65 and 74 who are generally healthy and active without major chronic conditions, research supports a systolic target in the range of 130 to 140. This provides meaningful cardiovascular protection while maintaining adequate organ perfusion for adults between 75 and 84 who are relatively healthy and functionally independent. The evidence supports a systolic range of 135 to 145. That range is intentionally higher than the younger group because the physiology demands it. For adults over 85, or for those who are frail regardless of age, a systolic range of 140 to 150 may be most appropriate. At this stage in life, preventing falls and preserving quality of life and independence carries weight that must be balanced against the long-term cardiovascular benefits of aggressive pressure reduction. On the diastolic side, the bottom number research suggests older adults should generally maintain a reading above 65. Ideally between 70 and 85. Diastolic pressure below 60 means the heart muscle itself is receiving inadequate blood flow during its relaxation phase, and that is a problem worth bringing to your doctor even if the systolic number looks acceptable. I want to tell you about Gerald. Gerald was 71 years old, a former electrician from outside Nashville who had been managing type 2 diabetes for about a decade. He came to see me after his previous physician had retired, and his most recent blood pressure reading was 147/88. His chart showed he was already on 2 blood pressure medications. His previous doctor had been working to get the systolic under 125. When I sat down with Gerald and reviewed his home readings, which he had been keeping diligently in a small spiral notebook, I noticed something his office visits had not captured. His morning readings were consistently around 142. His evening readings were around 136, perfectly reasonable numbers for a 71-year-old with his history. But he told me that twice in the past month he had felt suddenly lightheaded when standing up from his recliner to answer the door. He had not fallen. He had caught himself both times on the doorframe. He had not mentioned it to his previous doctor because he assumed it was just age. It was not just age. When I did orthostatic measurements in my office, checking his pressure lying down and then standing, his systolic dropped 31 points within 60 seconds of standing, 31 points on paper. Gerald had controlled blood pressure. In reality, every time he stood up, his brain was briefly starved of adequate circulation. We adjusted his medications carefully, accepted a slightly higher resting target, and Gerald has not had another episode in over a year.
What Gerald experienced has a clinical name, orthostatic hypotension, and it is far more common in older adults on blood pressure medications than most people realize. A study published in the European Heart Journal found that orthostatic hypotension affects nearly 20% of adults over 75 who are being treated. For high blood pressure, 20%, that is 1 in 5 people sitting in your doctor's waiting room, and the majority of them have no idea it is happening because nobody is checking for it consistently. The American Heart Association recommends orthostatic blood pressure measurement as a routine part of cardiovascular assessment. In older adults, but in a 15-minute office visit, with a full problem list and medication refills and lab results to discuss, it frequently does not happen. So I am going to teach you how to do this test yourself tonight, because this single measurement could be the most important health information you collect this year. You will need a home blood pressure monitor. They are available at any pharmacy for around $30 and are one of the most valuable health investments a person over 65 can make. Here is the exact protocol. Find a comfortable place to lie flat, your bed, your couch, lie down and rest for 5 full minutes. Do not skip. This step, the 5 minutes of rest, is what establishes your true baseline. After 5 minutes, take your blood pressure while still lying down and write down both numbers. Now stand up, and this is important. Take your blood pressure again immediately. Do not wait 2 minutes. Do not walk around first. Check it within 60 seconds. Of standing, write down those numbers. Now compare them. If your systolic pressure, the top number, dropped by more than 20 points between lying and standing, you have orthostatic hypotension. If your diastolic, the bottom number, dropped by more than 10 points, same conclusion. This is a red flag that warrants a direct conversation with your physician. Bring your written numbers. Do not just describe the sensation of dizziness, bring the actual measurements. Physicians respond to data in a way they cannot always respond to symptoms described in words. Let me give you a concrete example of what dangerous orthostatic hypotension looks like on paper. Your lying blood pressure is 126/79. Looks excellent by any conventional standard. You stand up. Within 60 seconds, your pressure is 94/61. That is a 32-point systolic drop. Your brain, which receives no advance warning and has no reserve to draw on during those seconds, is operating on inadequate pressure. You may feel it as a momentary darkening at the edges of your vision, a sense that the room shifted, a need to grab something solid, or you may feel nothing at all and simply fall. The absence of symptoms does not mean the drop is not happening. This is what makes orthostatic hypotension so dangerous. It can be entirely silent until the moment it is catastrophic. Now I want to get to the point I told you about at the beginning, the most dangerous element in this entire conversation, and it is not about how high your blood pressure is running. It is about something that almost no one is monitoring, and something that standard office visits are structurally incapable of catching. Blood pressure is not a fixed number. It moves throughout the day in response to activity, posture, meals, stress, sleep, and medication timing. A single office reading taken at 10 in the morning while you are sitting calmly in a chair after a short walk down a quiet hallway tells your doctor almost nothing about what your pressure is doing during the other 23 hours of your day. Research published in the journal Hypertension found that blood pressure variability, the degree to which your pressure swings up and down across the day, is independently associated with stroke, cognitive decline, and cardiovascular events in older adults. Not just the average level. The variability itself, and excessive blood pressure lowering with medication, does not reduce variability. In many older adults, it actually increases it because the medication blunts the baseline, but the body's compensatory mechanisms, already slowed by age, cannot smooth out the peaks and valleys the way a younger cardiovascular system would. This is why home monitoring over time is so much more valuable than any individual office reading. I recommend that any adult over 70 who is being treated for blood pressure check their pressure at the same time each morning before taking medications, and again each evening, for at least 2 weeks before any medication adjustment. Discussion with their physician. Keep the log written, not in a phone app that your doctor cannot easily review, but on paper that you can bring to the appointment and hand directly to your provider. 2 weeks of morning and evening readings gives your doctor something genuinely useful: an average, a pattern, a sense of whether your pressure is stable or swinging. It changes the quality of the conversation entirely. I also want to address something that does not appear in enough of these discussions, and that is the connection between blood pressure management and cognitive function in older adults. A study from Johns Hopkins followed adults over 74 years and found that those who experienced repeated episodes of orthostatic hypotension had significantly faster rates of cognitive decline than those with stable pressure. The proposed mechanism is cumulative. Each episode of reduced cerebral blood flow when standing causes microischemic injury, small areas of the brain receiving insufficient oxygen, not enough to cause a stroke, but enough, repeated over months and years, to accelerate the kind of cognitive changes that families notice before doctors do. The person who seems a little slower, a little more forgetful, a little less sharp than they were 2 years ago, sometimes that is not inevitable aging. Sometimes that is a blood pressure medication working too well in the wrong direction. I want to tell you about Carol. Carol was 67 years old, a grandmother of 4 who had retired from 30 years as a hospital administrator in Atlanta. She was sharp, organized, and deeply engaged in her grandchildren's lives. She came to me not because of dizziness or falls she had never fallen, but because her daughter had noticed over the previous year that Carol was repeating herself during phone calls and occasionally losing her train of thought mid-sentence. Carol's blood pressure had been aggressively managed for 3 years. Her most recent reading was 117/72. When we did orthostatic testing, her pressure dropped 24 points on standing. When I reviewed her home log, her morning readings before medication were consistently around 138, perfectly reasonable for her age. After medication, her afternoon readings were sometimes dropping below 110. We made a careful, gradual adjustment to her regimen over about 4 months, accepting a resting target of 135 to 140. Her daughter called my office 8 months later. She said Carol seemed like herself again. I cannot promise you that blood pressure was the only factor. Medicine is rarely that clean, but I can tell you that what Carol experienced is documented in the literature and it is reversible when caught in time. At this point, I want to pause and ask you something directly. If you are watching this, you are someone who takes their health seriously enough to seek out information beyond what fits into a 15-minute office visit. That matters. Write your age and where in the world you are watching from in the comments below. I read them, and if any part of what I have described today, the dizziness when standing, the fatigue that arrived around the same time a medication was added, the sense that something shifted but nobody could explain it, if any of that resonates, write that too. You are not alone in this, and your experience is not imaginary. Now I want to give you a specific and practical action plan, not vague advice, but concrete steps with timing, because information without action does not protect anyone. Tonight, if you are on blood pressure medication and you are over 70, do the orthostatic test I described. Write the numbers down. Do not wait until your next appointment to do this. Do it tonight. Tomorrow morning, before you take any medications, check your blood pressure and write it down. Do this every morning and every evening for the next 2 weeks. You are building a data set that will make your next doctor's appointment dramatically more productive at your next appointment. And if you have found a significant orthostatic drop or your home readings are consistently below 125, schedule that appointment sooner rather than later. Bring your written log and ask your doctor one specific question. Ask, given my age and my overall functional status, what systolic blood pressure range is associated with the best outcomes for someone like me, not just cardiovascular outcomes, but fall risk, kidney function, and cognitive health as well. That question, asked with your home data in hand, will change the nature of the conversation. You are no longer a passive recipient of a number on a guideline. You are a participant in a clinical decision that belongs to you. If you are experiencing dizziness when standing, unexplained fatigue, difficulty concentrating, or any new cognitive changes since a blood pressure medication was added or adjusted, do not dismiss these as inevitable features of getting older. Report them specifically. Describe when they happen, how long they last, and whether they correlate with standing up or with the timing of your medications. These details matter clinically and they will help your physician make a better decision. And finally, this is the part most people skip, and it is the part that actually protects you between now and your next appointment. If you live alone or spend significant time alone at home, make one structural change to your environment this week. Place a sturdy chair or grab point within reach of your bed so that when you rise at night you have something solid to steady yourself against in the seconds it takes for your blood pressure to equalize. This is not about being fragile. Margaret was not fragile. She was careful and organized and did everything right, that is, except know that her medication might be working against her in the dark at 2 in the morning. You know that now, that knowledge is protective in a way that no medication can be. Here is what you now understand that most people your age and honestly, many healthcare providers do not fully appreciate. Blood pressure targets are not universal. The physiology of aging demands different numbers, and the research now supports those different numbers clearly. For adults over 75, a systolic pressure between 130 and 145 is associated with longer survival and better functional outcomes than the conventional target of below 120. Orthostatic hypotension, the drop that happens when you stand, is often more immediately dangerous than moderately elevated resting pressure, and it is detectable with a $30 monitor and 5 minutes of your time. The cognitive changes that families notice and physicians too often attribute to normal aging are sometimes reversible when the medication regimen is reassessed with age-appropriate targets in mind. You now have the language, the data, and the clinical framework to have a different kind of conversation. With your doctor, you sit. The people who get the best care are not always the sickest. They are the most informed. You are now among them. Share this with someone you love who is over 70 and on blood pressure medication. It may be the most important thing you do for them this year. And if this gave you something real today, something you will actually bring to your next appointment, subscribe, because this is the work we do here every single week.